Good morning and a warm welcome to day 2 of the Healthcare and Infrastructure E-Summit. We would like to thank our sponsors for this summit, Everest Boats and Hipla Technologies. Let us find out what we have in store for us for day 2, session 3 on patient care experience through digitalization.
I think the right time is the designing phase. That's where I feel all your expertise have to come on table. People are savvy for technology. We are savvy for using new inventions. We are also trying to move away from the conventional way of systems. Now we have such a beautiful material like your boards, which we are using. So those have become very competitive over the time. We are doing one APMC market in Latur. There the whole concept is that we are putting all the prefab structures all together as a 7 lakh square feet of development. So it's supposed to be complete in 4 months' time. We were able to reduce 30 mm sizes to 19 mm sizes. We were able to reduce the structural costings of the facade. So there are so much of advantages of using the new things.
Let us begin the session with a case study presentation on how can we train hospital caregivers to enhance patient experience. Our speakers for this session are Mr. Neil Sequeira, VP, Human Resource and Administration, Kokilaben Dhirubhai Ambani Hospital, and we have Dr. Dhaval Bhatt, Assistant General Manager, Clinical Administration, Kokilaben Dhirubhai Ambani Hospital.
So good day to all of you who are going to hear us live today at the conference. And I am Dr. Dhaval Bhatt, and with me is my colleague Dr.
Hi.
Neil Sequeira.
I am Dr. Neil Sequeira.
Okay, so we are from Kokilaben Ambani Hospital. I head the medical administration, and sir is from the
I head HR and administration.
So sir, would you like to
So actually today we are going to talk about how what our patient experience is, how do we actually train our employees, how do we try our employees to meet patient expectations. Every patient who comes in is different. He comes in a very different psychological bent of mind. But as hospital staff, we have to try to ensure that patient gets maximum satisfaction. One thing that differs this business from other businesses is that every customer who walks in, is forced to walk in. Unlike a restaurant or unlike a hotel or unlike any other business that you talk about. So when the customer is coming in itself, he's extremely high on anxiety levels. So how do you train a staff? How do you make them capable enough to allay fears of people and deal in a situation where there is so much of negativity around?
Yeah, so that's what we'll be focusing on in our today's talk. So we will speak about patient experiences, their expectation, and how do we make our staff walk those expectations. So that's what our talk is going to be all about. So we'll be taking you through this staff training and patient experiences. So what we experience in daily life when patient comes, as Dr. Neil was telling us, that patients do not come out of choice. They come most of the time because they are forced to come into a hospital because something has suddenly struck them. And each one has a different expectation and each one has a different experience. So before we go into this talk, I want every one of you to be clear that there are some minor differences between patient experience, patient feedback, and patient expectation. So that's what I'm going to take you all through. So if you look at this, patient experience, by definition, what it means, it means encompassing all the range of interaction that a patient has in a healthcare system, which may include, his interaction with doctors, nurses, staff, hospital management systems, and other facilities of the hospital. So patient experience means these are the things which he or she should be undergoing or should be experiencing while they're staying to the hospital.
And to interject here, let me tell you one more thing, that many a times it is also his experience and his passive observations of a lot of things in the system. For example, a patient may be sitting in a waiting room and see two nurses talk. That adds as a part of the experience because he's just passively watching them.
Correct. So it is active as well as the passive experience with the patient gradually builds up in his mind. And based upon that, most of the hospitals or most of the healthcare player, we try to objectivize those experiences through a rating system, which we call as patient satisfaction. So that is a basic difference. So patient satisfaction is generally a outcome of the positive patient experiences that he or she has within the healthcare system. So this is the basic concept which we want you all to understand. So now I'll tell Dr. Neil, he's an expert in this, that, how do we gather the patient experiences? Because most of the time, sir, we all are dependent only on the patient rating our healthcare system through patient satisfaction scale or some or the other form of a rating mechanism that we have.
One of the earliest management techniques, which was used by Ford and were used by managers at Ford, was management by walking around. And that's why, when you take your rounds in the hospital, when senior people take their rounds in the hospital, it could be doctors, it could be administrators, and you walk, you see a lot of things around. You see, how your system works. You see the queue. A queue in front of an admission area tells you the efficiency, or it tells you to actually interject and actually, sort out any particular issue. You also are able to see how well the patients are interacting with the staff, and more importantly, how the staff is interacting with the patient. And you can gather a lot of information, passively by just going around and seeing the systems and the processes. For example, when I take rounds around in the hospital, I sometimes see, there is tissue paper lying around, or caps lying around, or masks lying around. It talks about how efficient my housekeeping supervisor is there on that floor, because he should be seeing this. And when I look at that, I imagine what feedback the patient must be thinking about.
Correct. So as sir said, management rounds and patient interaction, it's very important even to interact with patients while you're on round. The relatives, they'll come up with suggestions, they'll come up with their own experiences. So this is where, you gradually start building up your diary and you start noting down the experiences that they have. Another is, each one of us have different type of a service level agreements, or, every organization has either actively or inactively or passively created certain type of service level expectations. So we should do, or we should conduct periodic audits of the same. For example, like sir was mentioning about housekeeping. So if you're going to have a housekeeping audit, then there should be walking around, somebody doing a tissue paper check. So if I'm going to move the tissue paper on certain articles, and if I found that the dust is there, I know that dusting has not happened properly. If sometimes it happens, there is corrosion in the operation theater, very high value, costly equipments getting corroded. So the improper use of chemicals have happened while cleaning those equipments or those machineries. Similarly, patient feedback or problem analysis also gives you some insight into the patient experience that they have had. Also, many places now we call back the patients or the patient relatives for feedbacks and comments.
This is a very, very important thing. In every service industry, you will have problems. Every service industry. Imagine yourself walking into a restaurant. You go there, you ask for a dosa, and then when he brings the dosa to you, you see that the dosa is cold. Now you're already upset that the dosa is cold. You call the waiter and you say, the dosa is cold. He'll say, sorry, this is the dosa we have, you'll have to eat it. Now that will bring you huge amount of dissatisfaction. What is very, very important in actually creating a lovely experience to any customer is the way you handle the complaint and the way you handle the feedback. The fact that somebody from the hospital actually calls me back and is actually taking cognizance of my complaint itself is a satisfaction creator for any customer.
Correct.
I may at the end of it not be able to do a great deal about the complaint. I'll give you an example. For example, parking space. In a city like Mumbai, everybody wants parking space, and parking space is limited across the hospital. But if I call a patient and I say, we got your complaint about parking space, we look into it, we are trying to sort it out, it is a great satisfaction creator for the patient.
Similarly, we also carry out, like say, the professional hospital like Kokila Bain or big hospitals, we do patient experience surveys. Now, there are very professional manners in which it can be carried out. So, for example, there is this CAPS survey, which is Consumer Assessment of Healthcare Provider and Systems. Now, this is a very, very professional way to conduct a survey where, you take actually patients who have got discharged or who are, within your healthcare system. You take their feedback or you take their point of view in this survey, and you will understand where are the service gaps in your system. So, it typically talks about accessibility, whether it was easy for them to enter the hospital, were they welcomed enough into the hospital, did they feel welcome, or there were obstacles, or there were, typical type of, speed breakers that were created in the process.
Were they made to move from one floor to another?
Correct.
What was the response? How close was the billing counter to the place from, where they actually got in? Correct. Were they made to move from one end to another? So what is the environment? Was there adequate seating space? How does the place look? How does the place feel?
And were we able to, like say, specially abled people, were they taken care of? Like, not many people nowadays come with relative. Somebody wants to walk in directly into the hospital and be independent by himself or herself. So are there enough facility, infrastructure is supportive enough, staff is supportive enough? That's what we define accessibility as. Similarly, with the physical environment, that when they enter, what do they feel? Do they get a typical smell of a hospital, which most of the patients nowadays don't like? So, or do they feel something else? So that's where, the physical environment comes in. If they walk into a patient's room, then how is the patient room? Is it shabby? Is the bed properly made when they are going to get admitted into the room? Or, somebody is going to still come and make the bed for them? Or when they're going to go for, say, a typical diagnostic test, then, were everything explained to them? Was everything available over there? Was the chair, or, the phlebotomy chair, or the CT scan couch, all these things comfortable enough for them? So these are the type of physical environment they are looking at.
In today's environment, was the environment clean? Was it sanitized? Did it make them feel safe? Was the staff wearing proper PPE? Did they appear to be properly trained?
Correct. So that this physical environment brings a sense of safety to the patient and the patient relatives. So they, like say today in COVID's pandemic, most of the people are actually reluctant to go to hospitals. They feel that the hospitals are not safe environments. So how do you make them feel that? Actually, you will need to deploy lot many resources. You may need to train your staff. You may need to have certain type of physical environment to look after this pandemic as well. Similarly, care outcomes. So patients come not for beautiful buildings, not for beautiful looking staff. They come mainly for the care outcome. They feel that in this organization, I will get cured. So that's where, the patient experience has to be most focused upon. That, was everything explained to me? Was protocol properly followed, whether clinical protocol or non-clinical protocol? Was my medication protocol followed? So these are the things where, the care outcome or the physician outcomes or nursing care outcomes come into play.
How well was I treated by the physician? Was he courteous? Was he nice to talk to me? Did he listen to me? Did he give me adequate amount of time? Was he sensitive enough to understand my problem? Did he actually? In India, many patients want the physical examination to be done. Did he actually touch me and examine me? Correct. Then is the management system. How accurate was the bill? How fast was my experience of admission? How quick were all the queries resolved? If there was a TPA query.
The turnaround time becomes quite an important indicator in the patient experience. So if wherever you find that your turnaround time is getting delayed or it is not up to the mark, that means there is some problem in the patient experience which is happening. Similarly, management systems are a lot many. So like nowadays, people want accessibility to their reports on their mobile phones, on their devices. They want to be connected to the hospital. So these are the newer type of the patient experiences which are coming up in this digital era. So digital era has opened up a Pandora's of patient experience, and they've given opportunity to healthcare organization where you can be always in touch with your patients. And last but not the least, sir, we'll talk about is patient satisfaction.
So patient satisfaction actually finally encompasses everything. Now let me give you an example. There are many a times, most of us think that when we talk of patients in hospital, our customer is not only the patient, it's also the patient relative. Because many a times the patient who comes in, he's unable to talk, he's in a semi-conscious state. So the experience shifts on from the core customer, which is the patient, to the patient relative. Many a times we get feedback like, the patient passes away, unfortunately. We get a positive feedback stating that, your hospital did the best. We were treated very well. Unfortunately, our relative passed away. So sometimes, though the cure outcome may not be positive, still you can achieve patient satisfaction by the way you treat the patient relative and the patient. And when the patient relative realizes that the hospital did whatever best, the hospital, the doctor, the nurse, the technician did whatever best in their capacity to save the patient.
Correct. So it's the intent which matters, So if your intentions are good, then that they are always recognized by the patient or the patient relatives. And the outcome generally is also on the positive side. Now I'll take you to the next slide. So once you do this patient survey exercise, so you can actually classify the patient experiences would come out either in terms of infrastructure provision. So whether they are satisfied, not satisfied with your infrastructure. It will come out in terms of staff behavior. How was your staff behavior? Staff competencies, were they competent enough to handle certain type of emergencies, certain type of problems which they came up with? And was your staff efficient enough? Did they wasted some resource, time? Today, time is the most important resource, and system revamp. So our today's talk is mainly around, sir, staff behavior, competencies, and efficiencies, because we are going to talk about training the staff. So staff training related are these three things.
Dhaval, this is very easy to say. The challenge is, firstly, in our kind of business, we are extremely manpower intensive.
Correct.
And ultimately, the service delivery point is a human being touching another human being, or a human being interfacing with another human being.
Correct.
And each of these human beings is different. We are a very, very high manpower intensive kind of a business. And our customer also, actually on the other side, is also a human being. How do we make these varying things actually come together? I'll give you an example. Most of the nurses who come from South India, come from a state like Kerala. And many of our patients could be a North Indian. And there could be naturally a huge communication gap between what these girls are talking and what the patient understands. So how do we, it's a very big challenge to train, and it's a very, very big challenge to actually get these things moving in a scenario like a hospital, which is always sometimes, positively chaotic. I use the word positively chaotic because, there is so much of action everywhere around. And if an outsider looks at it, it looks chaos, but most of the times we know that it's positive and it's in the right direction.
Correct. So that's what our next slide is, sir, about. That is staff behavior. So these are some of the common training heads. So one is, most of us, we need to know about organization policies. So whenever any problem comes, our staff points out, ये तो हमारा organization policy है, ये तो हमारे policy के हिसाब से नहीं हो सकता है. So whether they understand the logic behind the policies is the most important thing. So I feel,
I'll give you a good example, though. For example, there is a patient. We have a policy where we do not allow outside food. You know that. You handle that. It is. And a patient says, my mom has cooked me a lovely dabba, or my wife has cooked me a lovely dabba. Can I have the food?
Correct.
Now the nurse will say that, no, sir, you cannot have this food because we do not allow outside food. The next question will be, why do you not allow outside food? Why this food is from my home?
Correct. So is it not safe? So this is a natural question which comes to us. So if a nurse is properly trained, sir, that, currently you are not in a state to eat your home food. We know your nutritional needs better. And that's why we would like to serve the food from our kitchen, which is equally hygienic in nature. And we try to make it as tasty as possible within our constraints. So that is how, the answer needs to go. But if they say it's our policy, it creates a conflict.
You just can't say, it's our rule and you have to follow the rule. Because these rules are applicable probably for my staff, but the patient will always question, why the hell should I follow your rule?
Correct.
The second aspect is communication. In any service industry, and especially in our business, it's very, very important to have communication. And now let me tell you where the challenge is. The challenge is that many a times the patient or the customer is somebody who does not understand medicine. He does not understand anatomy. And we have a doctor, we have a nurse, we have somebody who's probably trained to do that. How do you actually communicate and explain to somebody something which he doesn't know? How do you explain in layman's language what is a hernia repair? How do you explain in layman's language why a particular procedure needs to be done or why a particular medication needs to be done.
Correct. That's where, the decoding of the medical terminologies become very, very important. So gradually, we are training. I am sure, sir has been done a great job in training all our medical staff in being simple and addressing things in the layman terminologies. So many times, instead of using a complicated term, you can use a simple term to explain to them what is happening in their body. And most of us use our common sense to understand what the opposite person is trying to tell us. So decoding medical terminologies become very, very important when you do training with respect to communication
Not
skills.
only that, it also bridges the huge gap between known and not known. And it is an equally big gap like between have and have nots.
Correct.
When you use simple terminology, which we always encourage our people to do, it actually bridges the gap and it emancipates positive communication.
Definitely. So this is one very important point to note, that we need to communicate in a simple manner which is decodable by each one of us. Another thing which brings us to is training with respect to non-verbal communication. So many times, our staff, they have a different body language, and as they say that light travels faster than sound. So your eyes see the non-verbal cues first, then the what is being said. So if you have a positive body language, a lot of things change. Many times we observe, in our practice also, that some doctors are very successful and some are not, because of the positivity which they generate. When they welcome the patient, when they speak to the patient, they have an open-handed, open palm gesture. This is very, very important when you're going to be communicating. That also opens up the opposite person while communicating with you. Sir is an expert in this, so maybe
imagine a situation where the patient is in pain, having a severe abdominal pain post-surgery one day, and he presses the bell for the nurse to come. And imagine two scenarios. A grim-faced nurse comes in, looks at him, and she says, "Yes, sir." And he says, "I'm having stomach pain." She says, "Okay, sir." And she walks out. And then she may come and give him an injection. And imagine the same scenario. Another nurse comes in, smiles. He says, "I'm in pain." She says, "Just a minute, sir. I'll give you something to relieve the pain." And she walks away. A smile has made so much of a difference. And non-verbal communication is also important in showing attentiveness and showing intent. One very important attribute of patient satisfaction is the time, like Dhaval said here, is the time to which he is responded. He does not want, if he presses the bell and the nurse comes immediately or the housekeeping boy comes immediately, he feels that, wow, this is a great organization and everyone are up to their job.
Correct. So this is very important, non-verbal communication. So this non-verbal communication is very important, which is many times missed out in our training. So that's where, different type of training modules need to be developed. Next, we come to is teamwork. Hospital works as a team. There are players who have major roles, some players have minor role. That's how, sometimes we have main players like medical team and support services team. But both the team need to work together to bring out the patient experience. So that's where, you need to gel the people from top to bottom. And that's an art, that's a training challenge, which all of us are facing today. Similarly, there is patient relationship management. Now, this PRM or the CRM, as they call it, is not related to, like calling a patient on his birthday or his anniversary, wishing him, "How are you?" That's not PRM. PRM is when you go beyond patient care. So if a patient gets discharged, post-discharge, how do you train your staff that, you need to communicate back to the patient, "How are you? Are you feeling okay? Have you taken your medication? Are you going to come back for a follow-up? Should I help you with that?" So these are the things, which are now evolving in healthcare. And these are the newer horizons which we all need to cross as the time goes on. Next is assertiveness.
Our business comprises many times of saying no, right? And we say no, not because we want to say no, we say no because it's not good for the patient. How do you say no to a patient without upsetting the patient? How do you sometimes, because sometimes, he may be very, very difficult. He may be insisting. He may be very, very stubborn. That is one very important skill that we train our people on. How do you be assertive enough? How do you be polite enough and still refrain and you insist and you keep your ground without letting it slip away?
So assertiveness is the next key thing which all your staff needs to be trained upon. And next is communication under special circumstances. There are deaths, there are negative outcomes, there are stressful situations, there are aggressive people. How do you protect your staff at the same time communicate rightly to the patient? So this is where, lots and lots of training material is being developed. Like we have developed few of them where we train them with certain FAQs, frequently asked question, and what are the model answers for the same, so that our staff doesn't fumble in this situation.
You may be surprised that in today's pandemic situation, the world outside is high on anxiety levels. Once a patient is admitted over here, the relatives cannot visit a COVID patient. So their anxiety levels are naturally very normal. They want to hear about their patient all the time. And it is very natural for their aggression. We have continuously trained our staff and told them that, this is a very, very natural situation that they may face till the pandemic happens and how they are supposed to deal with it.
We take it to the next topic, which is staff competency. So here, it is more of a technical world where, your staff needs to be trained on certain technical aspects like phlebotomy, infection control, neonatal care, software usage. Here, the things can be easily achieved if you have the right trainers in place. So there are right trainers for right type of training. If it's an infection control training, you require somebody with an infection control background. Phlebotomy is more of a skill based. So somebody needs to train them, actually demonstrate, re-demonstrate, and make them do it by practice. Then they will learn phlebotomy the best. It cannot be taught in theory. So these are the theoretical and practical aspect which you'll need to balance when you make training for the same.
The second aspect is emergency. The efficiency of a hospital is always seen the way you are able to handle emergencies. In case there is somebody with a cardiac arrest who comes from how are various teams going to converge and save life? So what happens if there is somebody who's brought in with a stroke? You have to sort it out within the next half an hour or 15 minutes. It may be very, very crucial to whether the patient is able to live fruitfully or live in a vegetative state.
So here what we do is we use simulation a lot. We actually create a situation and rehearse it in that environment. Like we create that a stroke patient is going to come, and we track the door to needle time, and we will know exactly that whether we met the parameter or not and where did we fail. And that's how you train the entire team to be reactive in case of an emergency situation. Similarly is the medical and non-medical process training. Here a lot of training goes, nursing training. There are tons and tons of nursing trainers who are working round the clock trying to train on some topic or the other. But the efficiency of those topic needs to be judged. Similarly, like say waste management. Now I don't think many hospitals or many healthcare players, they lay emphasis on how to handle waste. But that's such an important aspect. It may create a lot of trouble. Like today's pandemic, waste management has come out to be a biggest challenge for all of us.
How do you segregate this waste from its origin? How do you segregate it? How does it move within the building? Which bins does it move within the building? How does it go out of the system? In which different bags that you put in? How do you sanitize areas? How do you ensure that after one surgery is done and the next surgery happens, any infection which has happened to the first patient is not transmitted to another patient?
So we have operated till now, in our hospital more than 100 COVID cases in our same operation theaters. But how did we manage? So there has been lots and lots of infection control practices, lot of infrastructural changes, and lots of training of our staff. I think 80%, sir, would be attributed to the training of our staff. Similarly, computer automation and proficiency. You will find across the organization people with different proficiencies in computers. And many of us till date are afraid of computers, using automation. So that's where, the mindset change, training them, actually making them hands-on onto the machine is where, your training should focus upon. Then we'll take you to the next, that is measuring staff efficiencies. Here, most important is minimizing waste. Now, waste is not always in terms of material, but you will find patient experience, the waste is in terms of time. So patients don't want to waste time. They don't want to wait. So turnaround time becomes very, very important.
Once the doctor says discharge, the patient wants to go the next moment.
He wants to fly out.
How do you settle the bills immediately? How do you impress upon the insurance company to clear its TPA bill? The second is how you deploy staff to ensure that they are efficient, they are effective. How are you going to manage it? Because many a times you are faced with staff shortage. Credentialing and privileging. Who is allowed to do what? You do not want an orthopedic doctor to go and check somebody's eye and vice versa, right? machinery and technology.
Yeah, so machinery and technology, you know, many times we find that people are not trained to use certain machines. Simple suction pump they don't know to use. Sometimes they don't know to even do a HGT, which is, you know, glucose testing. So there are different type of glucometers which are available in different organizations. So they come from different setups. So how do you train them in your environment with some simulation, with the help of some of your instruments, so that there is minimal breakage, machineries are maintained, and at the same time periodic controls are done. It's very important to do control that will not affect the accuracy of your machines. So that's where, you know, machinery and technology usage training becomes very important.
And then is measuring and improving performance. You have every department has its own performance indicators in terms of various other parameters. You have process indicators, and very important is patient feedback.
Correct. So that's how you try to, you know, even put in the efficiency training for the staff. So is there a formula, sir, to do training, you know, in what proportion we should do which type of
there is
training?
no necessary formula. It mainly depends upon, you know, the nature of work, the type of patients you're dealing with, what is the feedback that has happened, whether it's a technology that you're using, whether you can, today's world, we are using a lot of technology because we also are, you know, so many people in a building. We do not want any infection to spread amongst us. And how critical these areas are.
Yeah, so very important criticality with respect to outcomes. So if a person is working in a highly critical area like ICU, operation theater, then their training will differ from somebody who's working in a very non-critical area. But that doesn't mean that he or she is important or not important. So that's where, you know, you need to balance out, and you need to take time of each one of the staff to actually impart training. So how do you deal with imparting training and, you know, getting that time out?
So normally what we do is that people who are willing to do training, they are there. We tell them that, you know, this is important for them. They are supposed to attend. There are some people, irrespective of they think that training is not important. And that is the time, Dhawal, you know, we have to use the stick sometimes. It's unfortunate.
So we use the carrot and the stick method, right?
Yeah.
Okay. So thank you all, and it was great interacting
with you. It was a great pleasure. On behalf of me, Dr. Dhawal, who's a great colleague of mine, and the management of Kokilaben Ambani Hospital, wish you the best of health, and God bless you all.
God bless you all. Thank you.
Thank you to our eminent speakers for sharing their knowledge and expertise with us on how do we train hospital caregivers to enhance patient experience. Let us move on to the next session, which is a panel discussion on how to strengthen and improve the COVID-19 patients' experience in hospitals and also those in self-quarantine. Our moderator for this session is Dr. Gaurav Thukral, CEO, Healthcare at Home. We have Ms. Juhi Bhandari, Assistant Director Administration, Hinduja Hospital. We also have Dr. T.P. Aluwalia, Scientist G, Senior DDG, Indian Council of Medical Research, Department of Health Research, Ministry of Health and Family Welfare, Government of India. I would now request Dr. Gaurav Thukral to take the session ahead.
It is thereby necessary to re-invoke knowledge and faith in the general public, which in turn will strengthen our economy. Keeping this thought in mind, iDAC has come up with the Healthcare and Infrastructure e-Summit, which focuses on various aspects of the healthcare industry, including themes like construction and infrastructure technology, Ayushman Bharat government policy and funding solutions, patient care experience through digitalization, technology and digitalization of healthcare. And today on this panel, in this conversation, we have gathered to discuss about what needs to be done to strengthen and improve the COVID-19 patients' experience in hospitals and also in self-quarantine. And today I have with me Dr. Tejpal Aluwalia from ICMR and Ms. Juhi Bhandari from Hinduja Hospital. I welcome you, both of you.
Thank you.
Thank you.
So getting on to with the session, I will be sharing a small presentation with a few slides in which I am going to highlight the COVID scenario, and then of course telling you what home healthcare is doing in these times, of course introducing myself and my organization, and then what has been the experience of managing patients in home isolation. So I'm just sharing my screen. To introduce myself, by training, I am an intensivist. I've spent almost 10 years with Fortis Healthcare into managerial and administrative and clinical roles.
Will you enlarge it, please?
So this is the maximum I can enlarge it.
Okay.
And have been involved into clinical and administrative works, worked with NABH. But it was in 2012 that I jumped the ship into an out-of-hospital setting in setting up home healthcare, where we started home healthcare services first time in India. And I am now the Chief Operating Officer for Healthcare at Home. Very proud to say that we are the first accredited home healthcare organization and the only organization where I've authored more than 20 publications in outcomes in out-of-hospital or home healthcare setting. I also chair the technical committee for home healthcare accreditation for Quality and Exchange Institute and is actually involved with FICCI Healthcare Insurance Committee also. About my organization, I represent Healthcare at Home India, which is promoted by the Burmans from the Dabur and the founders of Healthcare at Home UK, which has been the pioneers of home healthcare in the world. We have two business verticals. One is hospitals at home, and second is where we work with all top pharma MNCs. We have served more than 6 lakh patients across 670 cities. We do specialized drug delivery more than 600 cities, have 24/7 e-monitoring of patients at ICU at home, which is our biggest competence. We manage patients in ICUs, we manage patients on home dialysis, on chemotherapies, on HDU-like facilities, and of course, home rehabilitation also. But there's a lot new work which we are doing in COVID times. And on a daily, on a monthly basis, I think we are touching more than 1 lakh lives. So that's the scenario. I don't think anybody can debate. India is now almost touching the top charts of per day patients with almost, we are touching now 1 lakh patients a day. And the good part is that the testing has increased, but again, in our discussion, we'll highlight that most of this testing is antigen testing and not the gold standard of RT-PCR. We have been good at the recovery numbers for almost 75% of patients recovering, and also have been fortunate with the case fatality rate of around 1.7%. At Healthcare at Home, we had to step out beyond what we were doing regularly, setting up hospitals at home to manage patients. And I think we have done a great job of managing patients for Delhi government in home isolation, where we would have touched more than 60,000 patients. And now with government of Karnataka also, where we would have touched more than 20,000 patients. We also work with corporates like Tata, Presto, IDEMIA, and many other, where we have started industry redemption services, where we are working with them very closely so that their employees are safe and their workplace intervention can be managed. We also ran helplines for general public in Mumbai, Pune, Bhopal, Indore, and also work for corporate helplines with Dabur, Airworks, Aditya Birla, Manipal, Cigna. It's a proud moment now that the insurance is covering all COVID-related expenses out of hospital also, including home health care, under all insurance policies as mandated by IRDA. We were also forced by the situation to get home sample collection for COVID RT-PCR, again, where we have done a good job in the metros and beyond metros. We are the backend for Fortis hospitals across to run home isolation program. And we are also successfully running isolation centers in Supreme Court of India. So this was something which was, I would say, the need of the hour, where right from people who had fever would pop up a paracetamol or go to a primary doctor, were not able to do that. And that's where we started with the free helpline. Free helpline became a need for doctor consultation online, to prescription generation, to doctor writing the COVID test and we saying, okay, we'll come and do the COVID testing. People becoming positive, and we're running the home isolation program for them. And people who could not be isolated at home, even making isolation centers in hotels and in government organizations to run them. And that's where the Delhi government thing also came forward, where the numbers were increasing day by day, and they wanted partners, professional partners, to manage patients at home. And I think that innovation has led to a major crisis aversion, where beds and ventilators at one point of time we thought we won't have, and where home healthcare has been able to take a big chunk of the patients outside the hospital, so that only critical patients who need to be managed in the hospital can be managed at home. So that was part of my presentation. I would now request Dr. Ahluwalia to kindly take us through his presentation.
Thank you. I'm Dr. Tejpal Ahluwalia, former scientist G and senior deputy DG, Indian Council of Medical Research. I started my career with the Ministry of Planning, looking after all India agriculture side, making estimates every 6 months for the country. Then I switched over to the Ministry of Commerce and Industry as a chief training officer for 6 years. Left that because of a lot of transfers and joined ICMR in 1974. Since then, I work in various positions in ICMR, and I am the founder chief of health system research in country, as far as ICMR headquarters is concerned. So my lot of work has been done on health system research, and I personally believe that unless and until we address the health system as a whole in an integrated manner, things are not going to solve, whether any kind of disease or endemic or pandemic, unless and until our whole health system, which comprise of all public and private institutions, family, and the smallest unit as a person as a whole. Unfortunately, in India, health is given the least priority. Where the health system, where the health should be in the center of the all activities. Because whatever the activities we do it only for two things, either for physical enjoyment or for financial enjoyment. So the health system works in the environment which is political, historical, demographic, epidemiological, geographical, socio-economic, and cultural. As far as socio-economic is concerned, there are health needs community perceived, professionally determined, morbidity, mortality, disability, and antenatal care and family planning. Now, if we look at demography, health resources constitute taxes, user fees, insurance, contribution from donor agencies, staff and equipment, community labor, other sections. Politically, if we look from the health from political point of view, health policy and planning in relation to needs, resources, strengthening and changing existing interactions, and the interventions point of view, adequacy covering priority needs, coverage all risk groups, acceptability according to citizens' mandate, citizens' demand and culture, cost effectiveness, affordable for providers and clients, and equitability. And the health system works in the context of socio-economic, political, cultural, physical, epidemiological, which I already mentioned. It works from national level to regional level to district level, community, family, and the individual as a whole. There are private practitioners, there are 4 medicine practitioners, NGOs, international organizations, public works, water, sanitation, education, agriculture, healthcare. These all constitute the contextual factors for health system research. Now, for all kind of disease, including pandemic like COVID-19 healthcare concerns, there are healthcare concerns. Recently, most health system was caught up with COVID-19 containment activities. As a result, there was a dismal picture of patients' access to health services during the recent lockdown periods. Immunization dropped to 27%, institutional deliveries to 28%, major surgeries fell to 60%, outpatient treatment for heart ailments and cancer by over 70% and 51%. Now, what is the way forward, a possible way forward? Most of our health problems can vanish if we as a nation work together for it. Doctors, all other paramedical professionals, rural and urban citizens, bureaucrats, politicians, the state and the central governments. It is a national pain that after 73 years of independence, we still can't make even the basic healthcare services available, accessible and affordable to everyone in the country. Most of us sitting here in this summit probably haven't experienced the gloom of poverty, malnutrition, ill health, or global pandemic like COVID-19. We have probably never gone to bed hungry or lost a loved one because we couldn't afford a hospitalization when needed. 73 years ago, we freed ourselves from the British rule. It is now time that we should get freedom from ill health and start enjoying the fruits of good health and quality of life. As Vinoba Bhave had said, that the fruits of good health should reach the people living at the extreme end of our society. Then only we can say that Antyodaya has come to India as a productive force for national building in a historic way. Thank you. Jai Hind.
Thank you so much, sir, for those pearls of wisdom. And truly, we are quite privileged that we are still not at that extreme. But I think a lot of work has happened, and COVID has at least has not discriminated between rich and poor. It has treated everyone equally, and hence healthcare facilities and containment also becomes very, very important for every Indian or rather every citizen of the world. Thank you so much, sir. May I request Juhi Bhandari to kindly share her presentation?
Okay, so just to quickly introduce myself, I'm Juhi and I work for Hinduja Hospital in the capacity of an Assistant Director Administration. I've been working with Hinduja for the past 20 years, so almost my full life I've been here. Prior to that, I briefly worked with a hospital consultancy. So I started my career with microbiology, and as days evolved, I realized that I needed to get into hospital administration. My earlier career also was at Hinduja Hospital in microbiology, and I worked in the microbiology lab, and that's how I got inspired. And then I decided to do hospital administration from TISS. And after finishing my graduation, I came back to Hinduja Hospital and started working in the capacity of an executive in the marketing, and slowly and surely moved to operations, and then I've grown in this organization over the years. So 20 years actually is a long time. So it's like family. This place is like family to me. And actually at this hospital, we treat everybody like a parivar. And I'm very proud to be a part of this institution. So my areas of focus currently are basically operations, quality. I indulge a lot in quality. Like to take up Lean Six Sigma, projects, and patient focus. And COVID, as such, this coming of COVID, the pandemic has given us an opportunity to try and indulge patient experience in a slightly different manner. So how did we start this journey? So when it hit us in the month of March, we were not, it's not like, although I've said make a 3D plan, so at that point of time, we were not like actually, what to do kind of a situation. We were all very confused and we were all hit very badly. Having said that, we set up a COVID ward team in the hospital. And this team was like a multi-pronged team from the medical side, from the non-medical side, from the nursing side. So all of us were together in it. And we started taking baby steps in that direction. And we said that we need to look at the complete patient journey. We need to focus on a minimum contact solution, try to leverage on solutions like online, teleconsultation, video, etc. We tried to use social media, wanted to harp on our expertise, create channels for accessibility, wanted to give assurance of safety to our patients. We revised our visitor policy. We propagated social messages. And most importantly, that enrolled every stakeholder in the hospital. Could be just about anybody, even the attendant for that matter. And the whole process has to be evolving. So when we started off, it was something different, and slowly and surely it became more concrete. And right now we have a good plan in place. So when we created this whole plan, safety was our main concern, and we kept it at the center of the whole plan. So then we kept telling our patients that this is all that we have done for you. And we used different channels to do that. So the channels basically were, of course, within the hospital itself. But the fact remains that these patients were at home and we wanted to bring them back in over here. So initially we propagated ideas about teleconsultation. So we were not having teleconsultation before that. And our doctors were taken all on board. We actually trained them on teleconsultation to start with. And slowly and surely our ball started rolling. Okay. In the meantime, of course, our COVID ward, the number of beds kept increasing. So initially it was only 20, and right now we have about 78. And our IPD was only having emergency patients coming in, and now we have elective surgeries happening over there, and we reached an occupancy of 60%. And how did we do that? Basically, we spoke about safety. We kept harping on safety at the entrance, in the triage room, different buildings for different kind of patients, zoning for PPs, then only one attendant coming along with the patient. Social distancing was practiced. We have chairs in our waiting areas, out of which every alternate chair we have blocked. So simple solutions, sanitizers, availability of sanitizers at every location of the hospital, including the triage, corona curtains at various locations, especially the nursing stations and the outpatient area. All staff were assured that they will be getting the best PPE so that they feel comfortable to work in this environment. Acrylic shields for doctors in their cabins so that there is a barrier between them and the patients. Barriers for our receptions, and even simple things like disinfecting and spraying very often, and especially on Sundays, like a complete sanitization of the hospital. And of course, finally, the COVID care at home for remote monitoring of the patient. So this is all that we did, and we kept building an awareness. We used modes like our website, the social media, so that we can get in touch with our patients who are at home, that again and again reassuring them that we are there for you. So whilst we were doing all this, we realized there is also communication which needs to happen besides the digital communication. So we wanted to bridge the gap, and we used our existing appointment cell to do that. So the appointment cell was given with the ownership and the onus that they inform the patients about how to come to the hospital. For example, that you need to come by appointment, that you need to bring just one relative along with you, that you should wear your mask when you come, that there will be a triage which will be held, that if you have fever and if you have any influenza-like symptoms, then please refrain from coming. And if you have any queries, there's a special tele-triage number which you can call on, and you can ask your queries before coming here. That you need not come here to make your payments, you can do them online, that all your reports and payments and everything will be done at your home. So there'll be no queues and social distancing will be maintained. We also used simple solutions like voice calls, SMSs, WhatsApp, emails to be able to reach out to them. We also ensured that since we are now, on the social media like Facebook, Twitter, etc., the number of complaints tend to increase because people are now watching us, like trolling kind of a thing. So we ensured that we were there all the time. We're looking out to what they're asking us, what they're telling us, and that we ensure that we close all the complaints within a very small and reduced TAT. We also started something called as the admission counseling for our COVID wards, where wards for the do's and don'ts, we kept informing them that what they can do and what they cannot do. So they are aware of what's happening. We have a customer care team who calls the patients on a daily basis. We have doctors who speak to the patients on a daily basis. We have used tablets for communication between them so that at least you can see each other, because it's quite depressive to be in a COVID ward. You're kind of completely distanced from other people. We use video conferencing also with the psychologist so that we can help people during these difficult times. And yes, we also started a post-COVID care solution to the teleconsultation so that we can touch base with people when they are back home as well. And of course, we use patient testimonials to able to propagate what we are trying to say, the message. We're trying to send a message across to everybody.
Thank you, Juhi. And I must congratulate you being at the forefront. Hinduja always has been benchmarking healthcare in India, and I would say at the world level. And you have great leaders like Vinu, Gautam, and Joy who are leading from the front. I must say that you have done a wonderful task. But I have a few questions for you. And so my first question to Juhi, you have been 20 years in the hospital and being part of patient experience, quality, administration. हम हमेशा से ये बोलते रहे, patient से बात करो, barriers नहीं होने चाहिए, communication होना चाहिए, right? It is your empathy which you show by your expressions is what matters to the patient. डॉक्टर तो जब पेशेंट से बात करता है तो वैसे ही पेशेंट ठीक हो जाता है, And I had this experience 1 week back. My dad had to get an emergency admission in a corporate hospital where I have worked, right? It's in Fortis Hospital. And what I saw was barriers, as you mentioned, nurse station curtains, OPD curtains, billing counter curtains, doctors walking around in shields, right? Uh, in fact, I found it so difficult even that there is a curtain and then there's a shield and then there's an N95. How the patient experience has changed in all this?
You're absolutely right, Dr. Gaurav. It is completely a different scenario right now, and none of these barriers should actually be there in real time. But having said that, the situation which we are there in right now, there is something called as protection and safety. There's a safety factor which is important for the people who are working here, for the employees of an organization, for any staff, for any healthcare worker, and also for the patient himself. So this is something which is, what should I say, is not something that we would like to happen, but we don't have a choice. And this is the new normal, and I guess we have to live with it. But having said that, the communication channel is, yes, you're right. Like I was telling a colleague of mine the other day that now we can't see anybody smile. The only thing that you can see is the eyes. So we are all emoting through eyes actually. So the communication is become more focused on the body language now, which is the eyes and maybe the hands more than what you can see on the face. That's completely blocked. So I completely agree with you, but the situation has changed, and if anybody has a better idea on how to deal with it, we'll be more than happy to adapt it. We are very, what should I say, we are very broad-minded, and we're quite okay with that as well.
No, I think you have mentioned it very rightly. It's choice of no choice, and I think you have used telemedicine and digital media in a very big way. The way you are showing that even the patients who are isolated in the COVID wards, they are speaking through like we are speaking now with their doctors, with their dietitians, psychological counselors. I think these are the ways to bridge this communication. But truly speaking, we are not in the best of the worlds. And you said something very pertinent, that the safety of the healthcare workers is very important. It's absolutely right, because they are the frontline people. If they fall, then everything falls. And I remember in the very early days there was this outbreak which happened in the Hinduja hospital itself, which was a very tough situation to manage. So how are the healthcare workers on their side coping up with this? And what are the various things? How do you motivate them? I know you give them PPs and all, but how are they coping up with all this stress?
To begin with, when we started in the month of March, it was a challenging period to start with. Everybody was scared. Okay, we all had our doubts, including me, of how we were going to deal with it. But yes, we had to deal with it. And we realized that we need to enroll them in the process. And most importantly, we realized that they were very concerned and anxious about their families. Because when you're working in a hospital and you're working in a COVID area, what is the first thing that if I'm hit by it, what's going to happen? Okay, who's going to take care of me and who's going to take care of my family? So that we thought, let's address it from that perspective. Okay, anyway, our culture is a family culture, parivar culture. We are very proud to say that. So what we told them is that you don't worry, we are going to take care of you. So God forbid if anything happens to you, of course they are going to be admitted here because that is part of the deal in any case. That's part of the HRD. But having said that, we also built COVID centers, okay, our own COVID care centers for the male and the female staff separately, so that if they are not well, they can be picked up from home in our ambulances and they'll be brought up here and we will take care of them right to the time that they are well. As regards their families, the families we are admitting here if the family is unwell and if the ICMR guideline allows that to happen. But having said that, if there's any other help that they want from us, for example, if for some reason we cannot admit them at Hinduja Hospital, in such case scenario, we help them in getting admitted elsewhere. But we make sure that we take care of them and their family as well. So that was our main thing, besides the PP, of course. There were other simple things like, we had these dialogues with them and we asked them, what would make you comfortable? What is it that you want? So they said things like that, for example, the person who's sitting at the reception says that the patient is too close to me. Okay. Can we do something? Can we have a barrier? So we anyway had a glass barrier which had a cutout. So what we did is with the acrylic, we closed it. Okay. Then the next step is now we can't hear the patient because of the barrier. Okay, now that's another problem that has got created. So just today, we actually had a demonstration for that because the number of patients, our footfalls are increasing now. So that has become an issue. So now we had the thing like you have it at, at the theaters and the PVRs and all that. We are going to install one of those kind of systems over here so that you can hear. So it's like, it's a very evolving system, Dr. Tuklal. Every day there's a new challenge which comes up and we try to overcome that challenge. And the PPs, yes, at Hinduja Hospital, I must say that we've not shied at giving any PP that they've asked for. As long as they feel safe, because if they are safe, if they are happy, we'll all work well in that direction. We've also introduced a Sampark program, which is more like a fun program, and also a meditation and a holy and a spiritual side to it. So we have a meditation program. We have a pranic healing meditation program, which is the twin heart meditation, which actually I lead. And then we have another Maitri Puja with prayer, which another doctor leads. And then we have games. Okay, we have digital games. We have quizzes. We're going to have a talent show. So we're basically trying to switch their mind off slightly bit from the mundane, and the same thing, COVID all the time. So we're trying to kind of switch their mind off from there.
Yeah, so Juhi, you very well mentioned ICMR guidelines, and that takes me to Tejpal sir. Tejpal sir, you have been a veteran working with ICMR, or aajkal to ICMR whatever says is the gospel truth. Everybody waits कि ICMR की guideline आ जाए, तो उसके बाद ही करेंगे जो करना है. And testing has been something which has been intriguing us. I'm happy that we are doing, but from a time when it was कि सिर्फ यही लोग कर सकते हैं जो देश से बाहर आ रहे हैं, and then saying okay, we can do antigen testing, to now most of the state governments saying okay, you can do on-demand testing and don't even need a prescription. Sir, what is your view on testing? And then I'll further ask you on the various types of tests. What is your view on this?
The health system in India is still not integrated properly. One reason is health system constitute health financing, health economics, health infrastructure, physical infrastructure, as well as health manpower. They are not integrated together. So you give emphasis on one, the second will go down. You just raise it up, the other components will go down. If we want to understand the best health system is our own human body. Have we ever examined our human body for 24 hours? We'll get this all health problem solution, all disease solutions, just examining closely our own body for 24 hours. How we breathe, what we eat, when we get up, when we go to bed, how many times we watch television, etc., etc., etc. Now, regarding the ICMR guidelines, ICMR is a pioneer body as far as Indian health system research is concerned. We got 33 national institutes spread over India, 3 in Bombay, 1 in Pune, and 1 in Hyderabad, NIN, likewise other parts of the country also. Now, regarding the guidelines itself, 2 types of guidelines ICMR is issued, which are revised from time to time. And there should be no fixed guidelines as far as our country is concerned. The reason is, India is a country of about.
Sir, we lost you.
India is a country of about 100 countries, constitute more than 100 countries itself, as far as our population, our diversity is concerned. So ICMR, there are 2 types of testing. One is control testing, and another is on-demand testing, which ICMR just released the guidelines on 5th of this month itself, on-demand guideline. Now, testing for control testing is done for different type of population groups, rural, urban, within urban also, contaminated zones, low intensity zones. As far as testing on demand is concerned, this is a new concept coming over India. Whenever somebody is coming in the country or going within the country from one city to another city by air, needs a testing for COVID-19. It would have been better if we would have learned lesson from SARS-2, that is COVID-2 in 2002. We have not learned much lessons. Otherwise, we would not have done lockdown. This time, we would have properly handled the COVID-2 in 2002 itself. That's the unfortunate part of it.
And sir, my second question again in continuation is that people confuse between RT-PCR, rapid antigen test and antibody test, right? Some of the people I've met, हम एंटीजन करा लेते हैं, वो ना जल्दी हो जाता है, आधे घंटे में पता चल जाता है, और RT-PCR की तो रिपोर्ट आएगी आफ्टर 24 घंटे, तो 24 घंटे कौन वेट करेगा? Could you shed some light on the various types of tests, sir, and what needs to be done in which situation?
Testing, rapid testing and RT-PCR, they have got their own importance, depends on the what population you are testing. As far as rapid testing is concerned, you can consider it in a very economic way. It hardly costs about 100 rupees or so. So rapid testing can be done in most of the part of the population, where even symptomatic or most of the part asymptomatic cases are there. And once the test comes positive, and after the rapid testing, the patient develops certain symptoms of COVID, like headache, like fever, like pain in the body, etc. Then RT-PCR is much more useful, because RT-PCR you cannot conduct on the whole of the population because of its cost. Though ICMR has capped the cost 4,500 rupees RT-PCR testing, but it is not economical as far as our population is concerned, where 70% population still live in rural areas and can't afford this testing at all. So rapid testing, once the rapid testing gives you a result negative, and if after the negative results the patient feels then one can go for RT-PCR testing, which give almost 99% confirmed results. Because FAO, Food Agriculture Organization, and International Atomic Energy Organization both came together for creating this RT-PCR testing, which gives a very crucial result, because RNA and DNA matching together itself, and then the chemical is added, and if the color changes and comes to a certain pattern, the test is considered 99.9% correct. So that is the difference. They have got their own advantages and disadvantages depending on the type of population you are covering.
Thank you so much, sir. Thank you for these words of wisdom. And I'll go back to Juhi. So Juhi, now we spoke about COVID and everything, but there are non-COVID patients also, right? These are the patients who have been waiting for surgeries or are now landing up as elective surgeries, becoming emergency surgeries. And all these sick patients, I think one of the best things with any hospital like Hinduja did was to keep the communication flow very, I would say, flowing, right? And now with this fear कि मुझे तो नहीं हो जाएगा, या doctor saying that I don't know whether this person who's coming in is it. How are you managing this fear and communication and the experience for non-COVID patients?
So like I said earlier on, first of all, we have different buildings. So we have an IVR also at the appointment cells. When you call up, you hear this, okay, we have two different buildings. One is COVID, one is non-COVID. So right from there, from the appointment time itself, we're trying to drill in that message again and again and again. Okay? And that patient basically does a teleconsultation. When required to come to the hospital, if the doctor calls him, for example, if he thinks there's a surgery is required, he'll call him to the OPD, he'll get whatever his examination, his test and all that done, and then he'll be called to the IPD area. Sorry, the test, the COVID swab test, we're allowed to do that. So we do the test, and the test is negative, we admit the patient. And the ball starts rolling. So in the non-COVID area also, we have zoning done over there. For example, the ICU area, we consider as a red zone for us. The other areas are green and orange. And the PP, etc. is given there to the staff so that they are comfortable, and also the patient relatives. We allow only one patient relative, however, to come so that there is no crowding happening over there in the hospital premises. We take care of the patient's comfort as well, and also of the staff's comfort. So that's how we are basically managing the thing.
Thank you.
And my occupancy is pretty good right now. And honestly, we are quite happy about that.
Yeah.
We are looking forward to recovery.
Yeah, non-COVID people, they also need to be taken care of, although our all focus has gone to COVID. So going back to Tejpal sir, so when everybody is talking of vaccine आएगी और सब एक दिन में सब चमत्कार हो जाएगा, सब सही हो जाएगा, and people will be out on the ground. What is your view on vaccine, sir?
Those who are associated with the vaccine or vaccine trials or clinical trials know very well that even after testing, after phase 4 trials, it has to be tested on doses depending on the what kind of population you are covering, the upper crust, middle crust, lower crust, or the children. Depends on the type of vaccine which you are using. While a vaccine is one of the ways to prevent from causing further damage, there is no real evidence to suggest that the first vaccine made available to us will solve all ills. From the safety, dosage, administration, and abduction and production, a lot of factors needs to be taken into consideration before you pin our hopes on a vaccine. There are also newer researches which suggest that the vaccine may not be the most effective tool to fight the pandemic. People should continue to practice high levels of social distancing restrictions, wear a mask to control transmission rates. Hence, not just a vaccine, but pandemic could require behavioral changes on a personal and social level, and on COVID wage in India. वैक्सीन क्या करेगा साहब? ऐसा वैक्सीन क्या आप संडे मार्केट में जाइए, आप पब्लिक प्लेस में जाइए, आप मॉल्स में जाइए, आपको मास्क हटाए हुए या नाक के नीचे मास्क रखे हुए लोग मिलेंगे. 6 फीट का सोशल डिस्टेंसिंग मानते हैं. आप किसी भी सभी प्लेस में या किसी भी पब्लिक प्लेस में चले जाइए, आपको आज की तारीख के मास्क उतरे हुए मिलेंगे. वी आर नॉट प्रोफेशनल पीपल, वी टेक एवरीथिंग ग्रांटेड. तो जब तक प्रॉपर कम्युनिकेशन नहीं होगा, इम्प्लीमेंटेशन नहीं होगा इसका, जब तक लोगों का बिहेवियर नहीं बदलेगा, वैक्सीन कुछ नहीं करेगी. वैक्सीन ट्यूबरकुलोसिस के लिए भी वैक्सीन आया था. बैसिलीज उसी हिसाब से अपने आप को एडजस्ट कर लेते हैं. नाउ मल्टी ड्रग रेजिस्टेंस ट्यूबरकुलोसिस के लिए नए वैक्सीन ट्रायल्स हो रहे हैं. So vaccine is one component of it, and वैक्सीन दिया किसको जाएगा, कब दिया जाएगा, कितने पैसे का कॉस्ट करेगा, तो पॉपुलेशन को कैसे दिया जाएगा, हाउ द हेल्थ सिस्टम विल गियर अप. 1 करोड़ 38 लाख पॉपुलेशन है हमारी एज ऑन टुडे. तो वैक्सीन अच्छा है, सपना देखना अच्छी बात है, वैक्सीन ट्रायल होगा, बट इसमें भी इकोनॉमिक्स अंदर आई हुई है. जैसे रशिया ने अभी वैक्सीन ट्रायल किया, पूरा भी कर लिया, जल्दी में निकाल भी दिया, फिर जब केस फर्टिलिटी आया तो उसके बाद में now modifying again. So इसमें economics भी involved है.
Thank you, sir. Thanks for your views on the vaccine, and I completely agree that it's a behavior change which is going to be a lasting change, and this COVID is not going to disappear with the day vaccine is released. I completely concur with that. With that, I come to Juhi again. Juhi, any final words for the audience?
So I guess the challenge is not over. And we have to keep, change is the only constant thing which is happening, and we'll have to keep changing our methodologies and how to deal with it. And yes, I'm a little disappointed on hearing that the vaccine is not in the near future, because I'm tired of wearing the mask myself. It's a tiring process.
It is a tiring process, and it's taking its toll on the healthcare system itself. But yes, we have to gear through it. We have to pass through it. In fact, in East Asian countries, they have been wearing masks for last maybe 5 years, right? And they've made it a habit. But yes, we are still taking our own time. And I am from the capital of the country where the Chalta Hai attitude is much more than what Tejpal sir is saying. So Tejpal sir, any closing remarks from your side, sir?
We have to take care of ourselves. We have to follow the guidelines in a professional manner. Social distancing, masking in public places, never removing masks in public places. And whenever somebody is visiting your house, ask him to wear the mask and you wear your mask. So behavior change communication is saying is easy, but very difficult thing. But we have to propagate it. We have to make rules and regulations in such a way which are implementable and which are strictly implementable. That's my view.
Thank you so much, sir. And I would close this session by saying that we all need to remember one thing, that the life for the patient is not changing. A person who's undergoing surgery is still undergoing the pain. A person who's being treated for COVID is under a lot of psychological pressure. The life for a patient has not changed with COVID. The pain has not gone away. Rather, it has increased. And hence, we all have to put into efforts and more efforts so that we make the journey for the patient experience as delightful and as wonderful as possible. Thank you so much for your time, and thanks iDAC for this opportunity to us.
Thank you for giving me this opportunity. Thank you very much.
Thank you. Thank you very much.
Thank you to our eminent speakers for sharing their knowledge and expertise on how do we improve COVID-19 patients' experience. Let us move on to the next session, which is a workshop where we speak about a deep dive into the world of virtual patient care. Our speaker for this particular workshop is Mr. U.K. Anant Padmanabhan, Director, 10x Health Technologies. I would now hand over the session to Mr. Anant Padmanabhan.
Thank you, Danika, for the introduction. And it is my proud privilege to be a part of this wonderful e-summit. And the topic which that is given to me is very close to my heart. I am Anant Padmanabhan. I have been in the industry for almost 3 decades. I'm basically an engineer by qualification and worked in the large corporate hospitals in India, like Apollo Hospital, Powai Medical Center, MGM Hospital, Continental Hospital, Rainbow Hospital for the last 30 years. And I've been actively involved in the hospital operations and healthcare IT. Healthcare IT has been my forte. I have been implementing health IT in many of the hospitals. I have developed some softwares as well. And then in the last 4 years, I started one startup called 10x Health, 10x Health Technologies, which focuses itself on developing IoT solutions and artificial intelligence, working on artificial intelligence. Right now, I have developed one hospital operations system software, which is very, very new. And this tries to fill in the gaps that are there in the existing hospital information system. And I'm very sure that the industry will really welcome it. And so what I thought was today, I will talk about the strides that have been made in science and technology in the last 10 years, particularly in the field of IoT and artificial intelligence. Now people are talking about Industry 4.0, and this Industry 4.0 refers to the 4th industrial revolution. And the first revolution was somewhere during the 18th century, the end of the 18th century, when the steam engine was really invented and mechanization happened at work. But by the beginning of the 20th century, the electricity was found, and a lot of the mass production capacities were developed in many of the factories. Somewhere in 1970, the computers really made a lot of difference at work. In the workplace, many things were automated. But it was in the year, say 2010, when the Industry 4.0 was really coined. And that is the 4th revolution, when we found all these Internet of Things came into use. We were able to interconnect many of the systems. We were able to interconnect many of the devices, and that is how this Industry 4.0 came in. But how did now let us look at how healthcare industry really adopted this technology. And let me quickly hop into my presentation. The topic that is given to me today is healthcare the deep dive into the world of patient care. I would have really liked this topic to be a deep dive into the world of instead of the world, it could have been a universe of virtual patient care, because this universe is constantly expanding, and virtual patient care has become the norm in this today. In the last 4 years, I saw there was a tremendous potential for the disruptive and innovative technologies that are coming in. People were talking about the industry 4.0, the fourth revolution that was happening. Unfortunately, the healthcare was little slow in adopting technology. If you look at retail, manufacturing, banking, and transportation, they have been able to adopt this technology quite faster. But thanks to this corona, the COVID-19 pandemic, uh, I think the adoption of technology in healthcare has been accelerated. Uh, we found that the promoters and the owners of the hospitals who are not really adopting technology, and some of these CTOs and CIOs who are finding it difficult to implement certain technologies in the hospitals found it very handy this time during this time, and they were able to implement many of these technologies in the hospitals. And it was also interesting to see that there was a lot of push from the government, and many of these legislations like telehealth and all that got implemented, and telehealth became quite popular. Teleconsultations and all became very popular in the hospitals today. But what I thought was I will go little beyond telehealth. I'll go beyond teleconsultation, and then talk about some of the disruptions that have happened in the healthcare industry in terms of patient engagement, in terms of managing the hospital infrastructure, and how do we really ensure patient safety and caregiver safety in the times of COVID-19. So these are all some of the very innovative and disruptive technologies in healthcare. In the last, say, 10 years, these technologies have emerged, like Internet of Things, 3D, artificial intelligence, big data, genomics, edge computing, machine learning, internet, then wireless technologies like BLE, NB-IoT, and then robotic process automation, biometrics. There are at least about 20 technologies which are very active in healthcare. But I must confess that as far as India is concerned, there are about 7 or 8 technologies which I have marked in the asterisks are quite popular and are being used. And I'm going to show you some use cases in those areas. So when we talk about Industry 4.0, we are talking about, as I told you before, the end of the 18th century, the mechanization by steam and then water came the industry 1.0. And then the second one happened by the start of the 20th century, when electricity was invented, and mass production techniques were also adopted in many of the factories. That came to be called as Industrial Revolution 2.0. And in 1970, they started using computers and everything got automated. And I think it was in 2010 when the digitization of the enterprises happened, and there was the interoperable systems, and devices got connected, and machine-to-machine connectivities and happened. And we are now wondering whether Indian healthcare is ready for 4.0. This is the smart hospital framework which I have conceived. And today you find that many of the hospitals have hospital information system. They have clinical services, EMR for clinical services, and then for customer relationship management, they have the CRM, and they have hospital operation systems software. And this is a new concept that is coming in. We have only heard about hospital information system, but now people like us are proposing this hospital operation system software, which I have developed. I'm going to show you some use cases for that. Then you have the supply chain management. Then you have connected health systems, where remotely we connect the patients from the hospital to their nursing homes, to the old age homes, to even their residences. We are able to provide medical care using this connected health system. And then the new thing that has emerged is the National Digital Health Mission. And National Health Digital Mission is just coming into being, and I am sure it is going to make a huge change in the healthcare system, and it is going to be a path-breaking exercise. The entire Indian population will have a unique health ID. All the healthcare providers, all the healthcare institutions will get registered, and maybe we'll be able to store all our records in one platform and exchange that data. But maybe this is in the nascent stage. Maybe we'll be able to talk about it more in the next 2 to 3 years to come by. Then we have the infrastructure management, the building management system, and all these things constitute the smart hospital framework. And what happened was the industry 4.0, and this the COVID pandemic came into that intersection where the adoption of technology became very easy. In the sense, the COVID-19 wanted to eliminate human interaction wherever possible. It said we must minimize human interaction wherever possible. We must be able to enable social distancing, and we should be able to monitor certain certain activities like hand washing, wearing masks, and then we should also be able to remotely monitor patients in EICU settings, or maybe teleconsulting, and all these things became possible, became necessity, and that really helped in adopting these technologies. And I'm going to show you some of these examples now. Then with this intersection, I would say, intersection between industry 4.0 and the COVID-19 situation, I think gave rise to an emerging healthcare IT paradigm. And in that IT paradigm, I think the hospital operation system software, which is enabled by IoT, enabled by cloud and AI, became the centerpiece. And now all these the legacy systems like ERP, CRM, HIS, EMR, NDHM, and CHM are going to get interconnected, and at least will get networked through this hospital operations system software, which is emerging to happen. So the emerging disruptive technology convergence is one thing that is happening now, and you find that healthcare IoT enabled applications are there, and these IoT applications for healthcare, they work in tandem with some of the other technologies like wireless technologies like Wi-Fi, BLE, GSM, edge computing, artificial intelligence, IoT, mobile technology, robotics, and big data and cloud computing. All of them come together, and the technology convergence has made a lot of difference. So when we talk about the hospital's operation system software, which is very new to this industry, we talk about these are all some of the modules that have come up now: patient care services, security services, management information system, business development, support services, ticketing system, emerging emergency services, environmental services, biomedical engineering, building management system. What we must understand is this hospital operations system software has tried to fill up the gaps that are there in the hospital information system and other ERP systems, and they work together. And you will see here, for example, in one module, if you are talking about building management system, we can manage energy, we can manage power consumption, power quality, power interruption also we can monitor, we can DG power supply, solar energy, air conditioning system, maybe water supply, diesel. All these things can be monitored through this hospital operation system. And this hospital operation system gets integrated to the hospital information system and the IoT systems that are available, and you will find most of the hospital documentation processes get automated in this process, and we are able to gather a lot of data, capture a lot of data very, very easily, Either you can manually input this data using these forms, or these data can be captured through the IoT systems that are going to be in place very soon. See, this is another patient care service is another module, and there are about 12 modules, but I really cannot show you all the modules, but I can show you how they look. You capture this information, then you're able to get a report, and you're also able to generate dashboards instantaneously. Now, with the existing hospital information system, it is rather difficult to gather reports and then to develop dashboards, but here it is possible to do it very fast and using the low-code application. And this IoT and Internet of Things is a very interesting thing that has happened in healthcare. And these are all some of the IoT devices that are presently available in the market. You know, what you see there is the drip rate monitor. You can monitor the flow of IV fluids into the patient, how much volume of IV fluid has gone into the patient, how much is remaining. Now the nurses have to run up to the patient room. They have to run up, sorry. They have to run up to the patient room to find out how much of IV fluid is there. But here, these IoT devices send all the data to the watt station and they can see it on an iPad. And you have temperature sensors, water meters, you have gateways which work in this IoT system. And these are some of the IoT enabled systems that are available in the smart hospital, the intensive care, ward, ambulance, patient vital data charting system. We can connect all the infusion pumps, syringe pumps, ventilators, and all that to the IoT device, and all that telemetric data regarding the maybe the SpO2, pulse, heart rate, non-invasive BP, all that data comes directly to the electronic medical records, and 30% of the nurses' time is saved by directly getting the data from the equipment into the electronic medical records. We can monitor power consumption, and quality of power is also very important in any of the medical equipment settings. Then you can monitor the UPS, you can monitor the temperature and humidity of about 50 places in the hospital, whether they are operation theaters, whether they are intensive care units, laboratories, we can monitor all that. Then the heat, ventilation, HVAC systems can be managed remotely. We don't have to go near them to switch on and switch off. Then we can monitor LPG and diesel consumption. We can monitor water supply and consumption. We can even manage the transport systems where ambulances, all hospital vehicles can be tracked and they can be managed remotely using the GPRS system. Then we have wireless IV fluid infusion systems where the nurses need not have to go to the patient rooms all the time. And the next is the wireless people counters for social distancing. And this is also very interesting. These are all some of the devices that are kept in the cafeteria and in maybe in public places like billing, waiting area, to find out how many people are there in those places and whether they are maintaining the social distancing. I'm going to show you some of the practical examples of that. Then you have medical equipment location and performance monitoring. So you have real-time location tracking systems, and using this real-time location tracking system, we can know which medical equipment is located where. Is the infusion pump is in the emergency, or the infusion pump is in the ICU? Where are they located? We will be able to know the performance as well as the location of these equipments, because in a hospital setting, we will have at least about 200 to 300 infusion pumps. We will have about, say, 100 monitors. We could have about 25 to 30 ventilators. We want to know where these expensive critical equipments are there. So we also have nurse call systems, LoRa-enabled nurse call systems, and they are also becoming very popular. And this is the typical charting solution in a hospital setting. You see here, there are a lot of monitors, ventilators, infusion pump. It is where we have got the IoT devices connected. Now the nurse is entering all that data. But with these IoT devices, she does not have to enter the data. The data gets populated like this. So you find that 30% of the time is relieved for the nurses, and so they can really focus their attention on the patients and provide better care. This is a typical ventilator chart that has come directly from the medical equipment, that ventilator. And previously they were all doing it manually, and now in many of the hospitals, in the hospital where I am working, the MGM hospital, We have got about almost about 50 monitors and about 25 ventilators connected to these IoT devices. And this charting solution is very, very useful for the doctors and as well as the nurses. Then you have the temperature and humidity monitoring. What is happening is in many of these hospitals, we find that the temperature and humidity of the locations, especially in the operation theater, ICUs, laboratories, in many of the places, they are not monitored properly because they have to take the temperature once in the morning, once in the evening, and then record it. And it is a very cumbersome process. So once in these 50 locations to do all this is very difficult. It requires a lot of supervision. It is difficult to retrieve the data. And then sometimes the negative attitude of the employees, it is error prone and it takes a lot of time. And we are also finding there are a lot of missed entries there. So late recording of these data and human fatigue, they are all illegible. Paper consumption, these are all the practical problems we encounter when we are recording the data manually. But with these IoT systems, we find that we are able to track all those temperatures and humidity 24/7. Please understand, it is 24/7. There is no human intervention. If there are about 50 locations, and if there are even 50 equipments like refrigerators, freezers, cold storages, we are able to monitor the temperature and humidity remotely and accurately. And so this is a very classical case of IoT implementation and remote care in the hospital. And then similarly, the medical equipment monitoring, these are all very vital equipments like ventilators and infusion pump. You find that we have placed IoTs on top of them. And these, as I was telling you before, these devices capture all that data and then pass it on to the electronic medical records. And it is so good, and it is we are able to also monitor the performance of the assets. We are able to find out how long the asset has been working, how much to charge for the patient, and when to replace the asset. All that is possible, especially in a COVID situation like this. If the Tamil Nadu government, if the Tamil Nadu government has about, say, about 2,000 ventilators all over Tamil Nadu, we will be able to know how many ventilators are working, how many are not working, where are they located, in which district hospital it is available. It is something like the command center for the collectorate. We will be able to see all these equipments in one dashboard if these IoT devices are used and if these wireless technologies are implemented. So this is how you find it is all utilization. There's a classical, setting, ICU setting. You are able to see some of these very popular models of monitors, infusion pump being monitored, whether they are online, offline, how much they are utilized, what was the last location. All that is possible to be seen. And this kind of data, it is humanly impossible for anybody to go around and capture this data and start using them. And this is asset tracking is again a very interesting application. This is a new technology where we can track the assets, we can track patients, we can track employees, so that we can improve the workflow, we can improve the efficiency of the system, we can remove waste from many of these areas. And you find these are all some IoT devices. The first one you see is a Bluetooth low energy gateway. Another is a beacon card that is put on the patient, and the other one is a small BLE tag that is put on the equipment to track the equipment where it is moving. And then the other one is the ambient sensor. Another is the equipment sensor. All works in the BLE, and this is a typical setting. You find that these BLE tags are put on the biomedical equipment, the infusion pump. We are able to see when they went into the operation theater, when it came out of the operation theater, pre-operative, post-operative. We are able to see all that very clearly. And we can even track the master health checkup patients when they move from one place to another. We don't want them to waste their time. We want to utilize the employees' time very carefully. So we are able to know at what time a patient was in the reception, at what time the patient was in the lounge, when did you go into the consultation room, how long he stayed, so that we can optimize the time, we can optimize the facilities that are available in any of these areas like master health checkup. So this is only one typical application which I'm drawing. And this is an IoT enabled drip monitor I was telling you. this IoT-enabled drip monitoring system, if it is connected to all the IV stands in the patient rooms, then we will be able to know, monitor closely how much of IV drips have been given, what is the volume that has been infused, what is the volume that is remaining, and the nurse can remotely monitor it from the nursing station. So this is a very huge. This will definitely reduce at least about 25% of the nurses' time running up from one ward station to the last room of the corridor. So it will definitely reduce, like the nurse call system, it will also reduce the strain and also the work for the nurses. And this is a new technology that has been developed. You have got companies, and Dripo is one, Eves Lab is one company which is producing, and Zoho is also producing the drip monitor like this, and this is being used in many of the hospitals. This is an ambulance tracking system. This is very interesting. Again, we have about, say, 5 ambulances. We have about 5 cars for picking up the patients. We put an IoT device inside the ambulance. We are able to track the ambulance. We are able to know at what time it started, at what time it went into the patient, where they went to the place where the patient has to be picked up. Maybe a patient had a cardiac arrest and you have gone to pick him up. We know how long he took from the hospital to go to the house, how long he stayed in the house to pick up the patient, and how long he came, how long he took to come back to the hospital. So we are able to track every minute the vehicle, and we are also able to guide the technician inside the ambulance. So this actually gives you the start address, end address, how many kilometers he had, which also helps us to charge the patient using this. So this is a wireless cafeteria. You find that this is a typical LoRa-enabled counter. If you just put this device, we will be able to count how many people using the computer vision. It will not. It is not a video camera. It does not do video surveillance, but it definitely is able to get signals and then measure how many people were there inside that room, inside that cafeteria, and whether they have been able to maintain the social distancing. And it helps really to maintain the social. It gives you a graphical indication of how many people were there, when was that room empty, and when very too many people were there, how many people breach that social distancing norm. We will be able to do that. And this building management system is again a very interesting application using this new technologies for patient care, because we just want to monitor in cath lab. We want to monitor the temperature and humidity, because the humidity is very important for medical equipment like MRI, CT scan. And so once you put now here you find this is a device which people have to note down the readings, but once you put an IoT device in the room, then all the entire data is collected into the IT system. But this is a typical substation where energy meters, there are about 50 energy meters. All these energy meters are connected through the IoT system, and we can know the energy that is consumption, we can know the power quality, and this is how all these analytics come out of this. So previously it was very difficult for us in those days to collect the data, write some Excel sheets, and then present it to the management. And we were not able to reduce energy consumption because we didn't know where the energy was being wasted. But here it is possible to see every area. We can put a submeter and digitally monitor the energy that is consumed. And then here it was possible to switch off the AHUs. Maybe we had about 50 hair handling units in a hospital in an 11-storied building. In those days, we had to request the technician to go to each and every place, and then they have to switch on and switch off the AHUs at a particular time, which they did, and sometimes they did not do. But whereas with this, the new IT system, we will be able to schedule the switching on and switching off of these AHUs, and we are able to really save the energy because they don't run unnecessarily during the off times, when during the night time the air conditioners don't work. So this is then these are some of the big chiller equipments which can be managed using the system. And this is how actually this is one of the hospital, the Kaveri hospital, which has used this. uh, this tells you what is the return air temperature, what is the supply air temperature, and what kind of setting we need to set. All that can be sitting on a laptop. We will be able to configure about 40 to 50 of these AHUs, whether it's in the MRI scan or MRI conference hall or a CT scan or any place. We will be able to monitor the temperature, and we will be able to also change the settings of these AHUs on and off. So you can also get a dashboard like this to find out, MRI room, whether it is in the right temperature situation, whether there is a right temperature and humidity, and whether the electricity is, the power quality is okay, and what was the water consumption. All that can be brought in an energy dashboard, and hospital like us are all certified for LEED, and the LEED requires this kind of a dashboard to justify, to say that we are really monitoring the energy consumption and saving wherever it is possible. So these are all the things which I thought I should tell you, and this being used, and we have been able to save at least about 30% by way of wastage, and we have been able to get about 20% saving in manpower. And I am sure in course of time, most of the hospitals will start using this, and especially the hospital operation system software is a new technology that has come in. It's a new application that has come in, and I am sure many of the hospitals will make use of it. And if anyone wants any assistance in implementing all this, we are only too happy to assist. I must thank iDAC for giving me this opportunity, and it was a wonderful forum. And I understand a large number of people are attending this summit, and I'm sure everyone will be benefited by it. I want to thank iDAC once again, and it was my privilege to be a part of this enlightened gathering here. Thank you. Thank you very much. Thank you.
I would like to thank Mr. UK Anand Padmanabhan for sharing his views with us. We move on to our next session, which is a debate on digitalization in hospitals, the pros and cons. Our moderator for this session is Dr. Sanjeev Singh, Medical Superintendent, AIMS, Kochi. We also have Dr. Sujit Chatterjee, CEO, Hiranandani Hospital, Mr. Rupak Barua, CEO, AMRI Hospitals, Dr. Sunil Chandy, former Director, CMC Vellore. I would now like to hand over the session to Dr. Sanjeev Singh.
Good afternoon, everybody, and thank you all for joining. We are at iDAC Healthcare Summit panel discussion, and we are so proud to see very eminent panelists amidst us discussing a very relevant topic, which is digitalization of healthcare. As everybody knows, and more so during COVID time, that healthcare is large, it's complex, it's heterogeneous, and it's definitely dynamic. And the digitalization plays a very important ingredient in our day-to-day activity. More so in COVID times, we have realized that we need to be contactless. And then there are a lot of remote working, managing clinical management, which happens. And even digitalization is working very well with respect to public health services. And we have seen the Kerala model where there is an electronic surveillance, contact tracing, data recording, data analysis happening and feeding back to ICMR. So digitalization has played a very, very big role. It was adopted pretty well with private hospitals, but government too has a fantastic vision, and they have come up with the National Digital Health Mission. And they also made clinical management easy with the telemedicine guidelines. So I think we are seeing all gamuts participating, all stakeholders participating, and making it a good cornerstone for a fantastic foundation for a healthcare delivery system. And as somebody says that they are setting not just a system, but an ecosystem. So to discuss that, we have three very, very eminent panelists amidst us. We have Dr. Sunil Chandy. He's a very eminent cardiologist and was in CMC Vellore. He was the medical director there, and he has a superb vision and basically shaped CMC again to very next level, took it to a different orbit, and now he has joined as medical director at ITC. So thank you very much, sir, for joining us, and we look forward to hearing you. We are also joined by Dr. Sujit Chatterjee, a very active clinician and very well-known hospital administrator. And sir is a CEO of Hiranandani Group of Hospitals at Mumbai, and he plays a very, very phenomenal role in Maharashtra, in Mumbai, and throughout the country in providing his vision and helping in healthcare delivery. So thank you very much, Dr. Sujit, for joining us today.
Thank you. Thank you very much for having me.
We are also having Mr. Rupak Barua. Sir is a managing director and CEO of AMRA Group of Hospitals, another group which does phenomenal work and very, very extensive clinical as well as administrative work which has been performed for so many years, and they have changed the healthcare scenario in eastern part of India. So thank you very much for doing such great work, and thank you for joining us today.
Thank you so much, Dr. C, for inviting me.
Very good. So without much ado, we would like to get to our usual work, and I would be asking a few questions, and we would request you to be brief to the point and address as many as we can to understand basically whether digitalization is helping us and is going to make some phenomenal difference in the healthcare delivery system. So first question to you, Dr. Sunil. You were there with CMC Vellore. You were there shaping one of the oldest 100+ years of institution, which is an academic and a research institution. And you also have a very well homegrown EMR system. I have seen that, and I'm very proud that you were able to develop that. So with digitalization as a perspective, do you think that EMR is helping us, and what kind of impact it is playing right now?
Thank you for that question. So let me answer it from a CMC perspective, because you've taken that as a model of a very high volume turnover institution of patients. And our EMR is actually was never that. The word EMR was never coined, because 25, almost 30 years ago, when the floppy disks were available, those bulky computer systems, that's when it started. And it actually started, by a personal fad of one of the plastic surgeons who was very digital savvy, even at that time. This is in the 90s. And from there, it has grown to what I've seen it. So, I think it is definitely an enabler when you talk about large volumes. As you know, CMC has almost 8,000 to 10,000 outpatients. It is not now because of the COVID. Because CMC is a very large volume turnover, digitalization has come in to make it so optimized from the time the patient comes in to the time goes out. But let me just emphasize in 3 minutes, the approach that has actually evolved. It's not that this was a strategic approach, but in hindsight, this is what has happened in CMC, that we started with backend first. It was all about discharge summaries and billing, and the backend services of a patient's hospital experience was what was digitized, getting into medical records and all that. The core clinical part, which is the middle part, was untouched because we had no expertise in it. And then when that phase was over and we found that, bringing in the X-rays online, bringing in filmless X-ray technology through PACS actually made the clinicians very happy, and it saved time, and we increased our throughput. The volumes increased without any drop in quality of personal care. Then they went to the other end, which is the front end, which basically digitalized everything from the time patient steps into the hospital campus to register, to pay, to make it cashless, etc., etc. Even now we do not have a paperless clinical interface. It is only partial. And that is something that I want to stress that, this is probably the downside of digitalization, that if we are going to replace the human interface, the patient-doctor direct interface with this, monitor in the middle, and it's happening to the junior staff where they don't even connect to patients because you're busy filling in these details that, the patient is saying. You don't connect with them, you don't look at them. So it's become one 90-degree approach. You are talking to the monitor, hearing his history, not even connecting, and they leave very. So this is the problem of how do we now position digitalization without impacting medical, the quality of clinical care is the biggest challenge that we might face. But I must say that in CMC, they have managed to digitize the outpatient record. It is still pen and paper. But on the same day, it goes back to the medical records and it's scanned. So it comes as an image the next day for follow-up. The downside of this is that you can't do any research, you can't dredge that data, but it helps to keep both these segments of clinical care alive, that you are not allowed to, capsize the direct patient doctor interface. At the same time, the digital format is available. It is only now that about 50 to 60% of inpatient work is going directly into the computers. We've done away with long, lengthy paperwork that registrars and residents feel time they are allowed to directly put in. Our entire laboratory system is now online. There's no paper interface. So in an institution like ours, and I'm sure this has parallels in many hospitals in our country, the advantages of digitalization is immense, provided we can position it as an enabler, not as a replacer. It cannot, I believe, replace the crux and core of clinical care, the patient-doctor interface, which I think is the holy ground, the sanctum sanctorium of medical healthcare. We must not allow digitalization to replace that. So that's been our experience, and it will be good to know what others feel about it.
Very good, sir. I think very rightly put, it is a superb enabler, but definitely we need to be more patient friendly and communicate in a manner where he thinks that it is humane and not just with the system. So very true. So Dr. Sujit, you have been in this industry for so long and such a passionate clinician and a administrator, and handling such a big unit at one of those busiest area. There is so much of technology. There is digitalization with respect to IoT. There is mHealth. There is telemedicine. There is fantastic for clinical care. There is improvement in technology from zero point 0.3 Tesla to 7 Tesla. There is almost nothing to IMRT to IG. So, what do you think? Is digitalization improving anything, and how has been its adoption within the healthcare, and what has been its impact?
Let me take a line from Dr. Sunil Chandi's talk, where he spoke about, the patient as well as the doctor. The humane angle should not be lost. So I would like to quote from Sir William Osler: "The good physician treats the disease, the great one treats the patient who has the disease." So I think this is extremely important in modern healthcare today. The words of William Osler keep echoing in my mind when we talk in terms of various technologies which are there. Now, technology today is inescapable in medical care. You cannot do without technology. Yes, but there are immense uses of technology. For example, today you have a fully automated lab where human interference or the human interface, so to say, is minimized. And at the same time, results are linked through the picture archival communication systems. Information is linked all across. Now imagine a clinical situation where the neurosurgeon wants to see a couple of MRI shots and he calls for it and it's displayed on a screen. You know, rather than keeping on turning around and looking at pictures, he sees something which is on a display in front of him. To that extent, I think technology is completely inescapable. Computer assisted knee replacement surgeries. So the advantage there is the same joint which you are applying to a patient, which used to last maybe 8 to 10 years, today lasts 16 to 18 years, because cut, the cutting is so fine that it remains, the perpendicular architecture of the patient's frame remains constant, and hence the joint lasts longer. So to that extent, I think these things are extremely important. And what sort of an impact it has had? It has had a huge impact today. Uh, Patients come and feel at the hospital that if you don't have robotics and you don't have computer guided systems, you're not rendering top class care. I mean, that's the level of, should I say, the information dissemination. But it's not all true. You may have excellent monitors in your ICU, but if you are not able to interpret a blood gas which has been given to you, then no matter how much you display on your screen, when you've lost the lactates and you've lost the pHs, I'm afraid you're not going to do very much with the patient, despite the fact that you have brilliant machines which light up at the drop of a hat. So I think to that extent, William Osler was right that we need to treat the patient, but as Dr. Chandy has put it, that there is so much that is important with digitalization. See, patient records, for example. Yes, today even we are doing the same thing as CMC Vellore is doing as far as OPD is concerned. It's pen and paper, but that paper is scanned and that is archived. So it is reproducible. But there are many experiments that we have tried with, voice control and will it print on. We tried the EMR in the ICU. We failed miserably. So we went partial. You see, because in the ICU is one place where your doses are changing maybe every half hour. Now, how do you capture that on a system? I mean, you require somebody constantly entering data, which is not really correct. So therefore, we've gone into some of the records being electronic, but the main patient guide is definitely pen and paper. So while I say it has a huge impact, it has a massive impact. You were speaking about a 7 Tesla MRI. Well, the imaging quality is going to be fantastic. But let me tell you one thing. A 7 Tesla MRI is possibly still for the research centers. But the point of care may be a 3 Tesla or a 1.5 Tesla with a 48 channel. That might be as good as a 3 Tesla. But we must understand that the point of care must deliver the result to the patient. There's no point in having a 7 Tesla MRI and not being able to interpret the result very accurately. So this is what I had to say, and I would love to listen to the other panelists who talk in terms of technology. Thank you.
Thank you, Dr. Sujat. Very rightly said that we need to treat the patient who has the disease, and very honest submission, because we may not be still there, but it does has its impact in wherever the adoption has been pretty good. So we will circle back and see if any panelists have any other point of view. We will ask Mr. Rupak as well. Sir, during COVID times, we have seen that the patients were not able to come in, and then it's a difficult consultation. And very fast, Government of India, Medical Council of India earlier, and then adopted by Government of India, they came up with the telemedicine guidelines, and that became the new normal, that you could do that consultation, and it was very soon adopted by many of the clinicians. So, do you think is telemedicine way of consultation is the norm now? How is it doing, and is it cost effective?
Thank you, Dr. Singh. It is a very important question in today's pandemic situation. See, this current situation, pandemic part that which has exposed the vulnerability and inadequacy of the existing healthcare infrastructure in most of the countries. So, rising number of cases and has thrown a similar challenge before India as well. Now, healthcare spending in the country, in India, is 3.6% of the GDP, one of the lowest in the emerging developing countries. Now, the telemedicine part, which is coming out from because of the affordability, the major we talk about, there is the affordability of healthcare, affordability and accessibility. Now, these two parts actually can be detected in this kind of a telemedicine situation. The major question came up actually because there is a serious shortage of primary healthcare centers and the community healthcare centers. In the rural areas, there is a huge amount of shortage where the government hospitality having beds of 0.6 beds per 1,000 patients. These are the is a more actually came up for the telemedicine. Now, telemedicine is one of the most important part that is offering hope right in this pandemic situation. More we are talking about telemedicine, but telemedicine is always there for decades. The telemedicine, many of the hospitals, they have introduced telemedicine, though there is a lot of limitations. But yes, of course, telemedicine was there in the agenda. Now, in this pandemic situation, the World Health Organization also has recognized telemedicine as an essential service in this situation, in particular in this situation. So it needs to be adapted on a large scale in countries such in India, because the vast country is 1.3 billion population. And first, from the perspective of safety, as we were talking about the safety of our healthcare workers, so safety of our healthcare professionals who are at the forefront of providing service and therefore vulnerable. The second part is to increase the pool of medical professionals, because there is no geographic distance, no longer a concern actually. And even doctors in quarantine can pitch in as well. So in this pandemic situation, what we could see, there is a huge shortfall of the OPD footfall. Patient, both our internal customer and the external customers, nobody wants to interact each other in a physical way. And then the more they were talking about virtually how we can interact with the doctors, particularly the senior citizen and a little bit of those who are in the aged side. And that telemedicine actually adds help. And that is due to its benefits. If you are talking about, yes, telemedicine has surged, and it is increasingly finding its among the doctors, paramedics, and the countries as well. Now, when we are talking about the benefits, there are a couple of benefits we could see from the telemedicine in today's situation. There is one most important part is it's convenient. And as I had mentioned, there is the accessibility to the patient care. Because according to a Cisco global survey, what has been seen, that 74% of patients actually now prefer easy access to healthcare service and over in-person interaction. I mean, they do not want to interact with the persons and more and the providers as well. So that is a 74%. It's a global kind of a survey which has been done. And today's healthcare is a convenience is key. So it has taken up more pragmatic way, and people are looking for more better kind of a telemedicine setup in all over the places in the world. Now, telemedicine is it's a very effective effectiveness and healthcare savings as well, as we are talking about savings part. The remote analysis and monitoring services and electronic data storage significantly reduce the healthcare service cost, saving money and for you and for the patients as well, and for the healthcare providers as well. Telemedicine also reduces, that unnecessary non-urgent ER visit, unnecessary visit here that can reduce and eliminates transportation expenses and regular checkup as well. Now, one of the cost-effective part of the hospital as well, that there is a survey of the American Hospital Association also reported that the telemedicine program that saved 11% of cost in more of the, and then triple is an ROI for investors. So that is a huge amount of cost saving for the patient and for the service provider as well. There is one advantage, more advantage is an extended specialist and referring physician access. Anyone can get access to a very senior consultant, senior specialist as well, because as we have seen in this rural area, there is a huge shortage of the doctors, the specialists and all. And the people can easy at home, sitting at home, can get a consultant, a very senior specialist, and can interact. There is in this way, the major advantage of the telemedicine will be, that is your increased patient engagement. So patient engagement, because patients are very happy, and they are getting the doctors, the specialists, they are spending some more time with the patient, doctors, and doctors can give all kind of a reply their question, which is not possible during this year, their physical exchange of words. And that actually is, it really is giving better kind of a patient engagement. And the last but not the least of your telemedicine, which we can see, this is the quality. That is a better clinical outcome that we can see, as the clinical guidelines and pathways, if we consider, can be implemented through systems process during this year's telemedicine services and content them verified. So that's a that for the audit purpose, actually, definitely. So these are major kind of an advantage if we keep see this is telemedicine, and telemedicine is the only hope we can see pandemic and the post-pandemic situation.
Thank you very much, sir. I think that was very exhaustive, very lucid, and very to the point. I completely agree with you. It has really changed, and you mentioned almost about everything. The accessibility, it addresses the manpower shortage, the skill sets, which may not be there in semi-urban and urban, and you would be able to. So reach is extensive, and then you quoted that there could be an 11% saving. So that's an important kitty for any of the hospitals. So that's pretty inspiring and encouraging to learn. If the basics are right, if technology is working, if there is within rain, all systems are in place within rain, earthquake, storm, or wind.
Yes.
How do you think is artificial intelligence or machine learning or deep learning helping us, or is India ready, or where are we right now?
Yeah. So let me answer it from a very generic learned information, because I have personally, I must confess, no experience in AI, nor in machine learning, nor in IoT, because we don't have it here in Vellore. But Eric Topol's book called Deep Medicine actually explores the potential wonders of AI, and I think he's right that the amount of stepping up that AI will do into healthcare is going to be phenomenal. There's no doubt about that. For example, to arrive at a 99% accuracy in the interpretation of mammograms will definitely change the entire face of, breast tumors and oncology. So there's no doubt that there is going to be a data-enabled stepping up of the quality of health. But AI, how much it is going to impact us in India is still open to question, because the recent COVID experience is an eye-opener for all of us, that even if AI were available to us today and we were mastered ML and Internet of Things, I think we have seen quite painfully that our deficiencies were all on the ground. And therefore, I would stress that these are frills or the new gadgets and enablements with a complete robust system of healthcare, both in terms of infrastructure, the basic the IT capacity and manpower. Once you have that, then we can go to the next level, like Eric Topol doesn't even mention about, the deficiencies, because they don't have power shutdowns and they don't have anything called interrupted power supply. So they're at a different level where these things are possible. So all I'm saying is, while all these three things are on the threshold of taking healthcare and medical technology to a new level, which will definitely make it, very safe and easy for even practitioners. There's a huge chasm that divides us in India between this and the reality, which has just been exposed. The underbelly of where we stand has been exposed, and therefore I would be very, very guarded in saying that India is ready for AI. We are not. Honestly, we are not. We have to buck up our infrastructure, manpower, maybe a complete relook at how healthcare functions, and then adopt the relevant parts of digitalization and artificial intelligence in a very regulated manner. And there should be a body that, optimizes this, because I get worried looking at the webinars that are happening on the stated wonders of technology. It is almost like swaying our thinking to say that just take this and magic will happen. But even for magic to happen, you need a magician and you need the wand. Without that, there's no magic. So these are surely magic bullets, but it will work only if there is a huge man force of highly trained clinicians who are able to decipher between the discretionary talent of being clinicians, and to be able to say that, as Dr. Sujit said, this is where technology must stop, because beyond this, it is about compassion. And I don't think AI has got an input into that aspect so far. So a good thing in evolution, but I would confess that we are not ready to accept that, as we are going to really struggle with post-COVID rehabilitation, the entire healthcare system.
Right, sir. Thank you very much for those pearls of wisdom, because we completely understand COVID has taught us a lot, and then we are not there where we claim to be, and we need to get down to our basics correction before we really talk big. Prime Minister Modi went up on stage on 15th of August, and he declared a mega vision of national digital health mission. And it is definitely could be a game changer. It could be a path breaker. It could be a disruptor. But at least even the government is planning and thinking from that aspect. So, what do you think about this digital health mission? And are there any salient features which could be a disruptor?
Um, the Prime Minister has also said Atmanirbhar Bharat, self-reliance. So we have to be self-reliant holistically. We cannot be self-reliant in one aspect and dependent on others to help us out in various other aspects. So therefore, the Prime Minister, right from, I think, 16th of November 2016, has been so focused on the technology coming into this country. For example, when they did the demonetization, the aim was that everybody use credit cards. Now, if you will remember, in those days, in the early days, people were absolutely shocked because the main currency, or the trading currency, was the rupee. But gradually, even the local tea vendor started displaying a little sign says Paytm. But that was the first time that I had heard about Paytm. I did not know about Paytm. We heard about PayPal and things like that, which were, well, it's for others, it's not for us. See, and that's where this thing has started today. The online marketing, for example, is a big fad. So therefore, a lot of people are moving towards that. So therefore, as far as even the medical technology is concerned, the government of India must have very detailed statistics. I will give you an example. I had gone to Manchester what I wanted to start in my hospital a high-risk pregnancy clinic. So I wanted to know, like when you have inborn errors of metabolism, how do they garner this data, from where does it come, and things like that. At Manchester, they had data about India, Bangladesh, as well as Sri Lanka. The number of cases of inborn errors of metabolism. And that has been provided by our doctors like Dr. Suresh. He had supplied the data to Willink and they were recording it and we are not. So therefore, I think the time has come that we must understand that the government is very serious about capturing data, and it is not the duty of the government to start defining areas where this data is very permanent. For example, I'll give you an example of obesity. Most of us feel obesity is an urban problem. Sir, it is not so. Now the urban part of it is not so important as the rural part because of modernization, mechanization, the availability of internet, the availability of television, the standard buffalo and the hull, so to say, has been replaced by the tractor. And people are well-to-do. So therefore, obesity is becoming a huge problem in the rural area. Now, why should we not be able to capture data? So the data capturing, what the Prime Minister is really trying to do is to ensure that we are, one, aware that such things should be done, two, trying to set up the infrastructure, but most importantly, we've got to enter the data. So now we also require enormous bandwidth for easy portability of data. You might have collection of data at the periphery, but the real analysis may be at a data center. So therefore, the data centers are going to come up. Very recently, we've had a huge data center come up, the second largest data center. The data bank is in Panvel, just a few kilometers away from Mumbai. So I think that is so very important, and that's what the Prime Minister was trying to emphasize. Now, from there, if we go down the track of reality, then as Dr. Sunil has said, there is a huge deficit, and this deficit has to be made up by ensuring that the nitty-gritties are all filled in. So therefore, you have a process flow with the end result, which has a target date, and for which people are accountable. If these things don't match up, then every 15th of August, we will have a very good idea shared with us, but which we will see, not implemented and half baked. And if it goes half baked, sir, then I don't think we are ready, to march shoulder to shoulder or take on China. Apart from Ladakh, we will not be able to take on China in any other sphere. Let me give you just a small example. Today, a couple of weeks ago, I had a ransomware attack on in our hospital, but we have a complete mirroring of our servers, and the servers are not connected, interconnected. But if I want to shift data from one server to the other, I can. But there is a boom defense in between, and that helped us. We junked all these servers which were hit by ransomware and have taken on a new set. The new set of servers are being utilized, and we have taken on another set of servers as a mirror image. Now, this is a very, very small example of what the Prime Minister actually meant. That if you want to have a national direction of moving forward as far as information technology is concerned, then it is not only the mega thoughts which are required, it is the last mile which is very important. And if the last mile is not addressed, we will be nowhere. So I agree with what the Prime Minister says in spirit, but in kind, in action, I think we are far away, sir. And until and unless we realize that, or India as a country realizes that, we will be nowhere in the next decade.
Very true, sir. Very true. That's again a very passionate Dr. Sadit. We completely realize that it could be a very strategic decision, but until unless last mile is done properly, it will have no impact. And it is surprising that Indian data is all available with Manchester, and we don't have that data. Even we don't do anything about it. So what's the fun in having that data? Very right. So it's towards that reliant India that we need to march on, but there's a lot of work to do. So if we are at the end of our session, my last question would be to Mr. Rupak. In all this equation, patient is the most critical factor. Whatever we do, whether it respect to clinical care, support service, delivery, delight, experience, it's all about for the patients. So is digitalization improving satisfaction, patient engagement, his or her experiences, and are there any good success stories?
Yeah, Dr. Singh, that's a very important question, because whatever we are doing, we are talking our role is this is how we can give better care to the patient. This is so the today's modern healthcare is actually is the patient centric, absolutely keeping in mind of the patient. The digital process, what we are all talking about, the digital platform actually is a mean for major mean for operational efficiency, trying to better care to the patient, error-free care, and cost-effective, which ultimately end of the day is a CSAT or customer satisfaction. Now, here we talk about customer. There are two customers, as I was mentioning. One, our internal customer, the doctors, our healthcare workers, and the external customer, my patients. That is the two part, how we can the highest level. Now, if we see that that's a patient journey, and the journey starts from the outdoor. So the digital process actually has been so much of comfortability to the patient actually, because through mobile app anybody can book an appointment. If each and every hospitals right now, large hospital, they have their mobile apps that patients can book their doctor's appointment This is now all the hospital they are having in the mobile app. This is a payment gateway, so they can pay for the consultant fees, and they can reach out to the and they are getting on time the SMS that is your time of visit of the to the doctor such and such time, and also I can't forget. And I'm reaching there, the OPD of the clinic, the hospital at very right time without wasting more on unnecessary wastage of time. Now here actually this is what is happening today. There is the patients that are coming there, queuing up in the registration desk. There is a huge queue because there is hours, and the patients are sometimes getting impatient as well. So these are actually major kind of a in the OPD that the patients are getting benefit. That's absolutely patient centric. Now the patients, once that as all the other my fellow speakers are talking about EMR, because EMR is in the basic step of this your digitalizations in a hospital, and the doctor is doing everything, and everything is available through mobile. The patient's getting the medicine supplied from the medical shop. There is no need for the prescription, absolutely paperless. Then the diagnostic parts, only the QR code they can show, and it's the diagnostic is happening. Then there is, so each and every step, there is a lot of convenience and comfortability to the patient. Now, the time is the money. So definitely there is a huge amount of cost the patients are saving. Once the patient is getting admitted, the coming is my external, internal customers. Each and every process and system is an error-free. Now, the digitization process for the doctor's app, nurse's app, each and every clinical parameter is being fed. Patients are getting all the reports through mobile app. They can download from the mobile app. They do not want to come to the hospital for anything. They are paying through this your payment gateway. So each and every segment that the patients are getting healthcare on their fingertip. Now, billing update. That's a huge amount of dissatisfaction among the patients, actually the billing part. Transparency, it's not there. But once this is the digitalization process is complete for a hospital, each and every patient is getting the billing information, all the details are there. So, and patients are quite happy once they are getting the billing information. Nobody would like to this thing. And any further counseling part, yes, of course, there are the counselors are there, they can counsel. So patients, transparency part is there. Transparency between the hospital and the patient, that's the increasing, and patients are quite happy. As we have discussed already, there is a waiting time reduction. There is a huge waiting time reduction where there is no online appointment, everything that can be done. Now, this is one of the major areas also coming. That is your eICU. That is now most of the hospitals right now, it's coming through this eICU. That is one of the major for the customers. If we are talking about doctor as a customer, then the doctors are getting all kind of control from the any of the eICU around in the rural areas that we can control, and we can give much better care to the patient in a very cost-effective way. As we were talking about, now this your a case study. Case study so far, if you can see, there is a new system is coming up in the healthcare now. Post-pandemic, what we are expecting that there will be a new normal situation where from the quality care, we'll move to the value-added care or the value agenda, what we are talking about. Here, actually, one of the major, as we are talking about the cost, if you see there's a, regardless of the country and the culture, the cost of healthcare have a tendency to rise faster than overall cost. That we all know, which means healthcare consumes an over-increasing share of GDP worldwide. Here, actually, patients are talking about care at an affordable cost. There is a tremendous pressure we have health providers. There is a capping of the charges. There is a lot of schemes. There's a Ayushman Bharat. There's each and every state, they have their own scheme where you are getting you will have to offer to the patient a very concessional rate. Now, here is this is a value agenda, because from the quality care, because quality you cannot measure. It is not measurable, and quality can vary from one place to other place. You cannot define quality as any standard. It's very difficult to standardize the quality from the different perspective. So here actually value agenda, what we are now, it is coming up, and the digitization process is absolutely will take place. There are each and every, that is a treatment part. That is that the cost will have to consider. So suppose that is a patient is going for some investigations, then there is a through digital process actually will have to understand whether this MRI or any high investigation will give a sufficient return for the cost that the patients are incurring. And that will have to communicate to the patient why we are doing this, because this is a cost you will be able to save, because you will have to reduce your stay in the hospital for a couple of days. So this is called value agenda. This is coming up. This is a value added services to the patient. So value service which we are talking about to the patient, and through this digital process, we'll have to create a better kind of a patient hospital or the patient doctor relationship in the near future. Thank you, Dr. Singh.
Fantastic, sir. Fantastic. So I think that is very, very important to understand that patient plays a key role, and there is so much which could be offered to him. And you did mention about operational efficiency, transparency, and value addition. So those are very critical to the patient for whom we are having this healthcare. So very true. So we have shot our time, and it was so good to speak to all three of you. Just to wrap up, I think all of you touched a very, very important point. So if you have an uninterrupted power supply, and if you have going back to basics, and if you don't think digitalization is the magic bullet, and as Dr. Sujit quoted William Osler, that treating patient with the disease with humanness is important, and as Dr. Sunil Chandy sir mentioned about Eric Topol Deep Medicine book, and the enlightenment which this books brings to us, and Mr. Rupak, who mentioned that it is important to value add, but it is also key that the operational efficiency, cost effectiveness, transparency also improve. So possibly with all this, we hope and pray that we know digitalization is a big tiger, and it is there just outside our door, and it's going to have a tremendous impact. We need to be choosy. We need to see our scale of work, our scope of work, and understand what we can take from all the menu laundry list which is available to us, where we can deliver right kind of care and where we come back satisfied, but definitely with the good clinical management and with humaneness, that we are able to still treat patients. So that those are very, very important insights from all three of you. And I would like to thank Dr. Sunil. It was so good to meet you again after so long. Dr. Sujit, very, very passionate healthcare leader, and Mr. Rupak, phenomenal insights from you. So it was so good to speak to all of you. Perfect. I will just take 5 seconds from each participant. Dr. Sunil, would you like to go ahead with digitalization? Yes or no?
Yes, I would, but I would be very, very regulated, and what I can adopt in my medical scenario that I would be in.
Perfect.
I would not be happy to accept it as it is presented.
Right. Perfect. Dr. Sujit,
Thank you.
yes or no?
Yeah, yes, of course. But I would not like to be the first person to put my foot into everything. And I would not like to be the last also. So I would definitely see how things are panning out and then put my foot into it. But on the whole, yes, of course I would.
Very cautious leader. Yes, Mr. Rupak, yes or no?
There is I do not have the guts to say no. Yes, of course, the only way healthcare can provide better care at an affordable cost. So there's the digital is the imperative in the healthcare system.
Right. Perfect. So I think we had three fantastic panelists, and we discussed almost everything. We discussed EMR, where it was mentioned that clinical management is important, end-to-end management care is also important. So it is good to adopt. We also discussed digitalization of health, and Dr. Sujit mentioned about, yes, 7 Tesla is good, but possibly for research, but it is good for knee replacements, and adoption is good. We discussed telemedicine, where Mr. Rupak did mention about accessibility, convenience, stopping unnecessary visit, and 11% of cost saving. And if we have shortage of manpower, why not adopt telemedicine? Then we also know about artificial intelligence. It is happening, it is there, but maybe it is too soon to comment. There's a lot of challenging work, but maybe our infrastructure needs to be more robust to adopt it. Dr. Sujit mentioned about the National Digitalization Mission being self-reliant. It's important. He quoted obesity example. He quoted the Manchester example. The data is there, but and then on the self-reliance part, there is a cloud management which is happening in Panvel, and that is remarkable work. So there's a lot of work which is happening. On the end, we discussed about this poor patient who comes to the healthcare setup with a lot of trust. And through digitalization, there could be a lot of operational efficiency, transparency, and a fantastic value add. So we are moving toward a QR code based management system, but so be it. And hope that it could be, though cautious, though clinical care is supreme, but we, in a graded manner, adopt digitalization in healthcare delivery. So fantastic to have all three of you.
Thank you, Sanjeev, for moderating it so efficiently. Thank you.
Thank you, Dr. Sanjeev.
Thank you.
Right.
Thank you very
Thank you.
much.
Thank you.